This is Where We Live from Connecticut Public Radio. I'm Catherine Shen. Throughout the pandemic, public health officials have raced to relay the science of COVID-19 in real time, particularly in those early days that we might prefer to forget. But as the virus has evolved, so have the pressures that face public health messengers. Acclaimed scientist and Connecticut native Dr. Peter J. Hotez was recently accosted outside of his Texas home. It was a part of a larger push for Dr. Hotez to debate anti-vaxxer and presidential candidate Robert F. Kennedy Jr. Coming up, we revisit our conversation with Dr. Hotez all about his forthcoming book, The Deadly Rise of Anti-Science, A Scientist's Warning. You can find the full interview online at ctpublic.org/wherewelive. But first, the World Health Organization recently announced the end of the COVID-19 global health emergency, but the pandemic isn't over. And joining us now to discuss is Dr. Saad Omer. He's an internationally recognized epidemiologist who was recently appointed Inaugural Dean of the School of Public Health at University of Texas, Southwestern earlier this year. And he was also previously the Inaugural Director of the Yale Institute for Global Health. Thank you so much, Dr. Omer, for joining us this morning.
My pleasure.
And what questions do you have for Dr. Omer? Feel free to give us a call, 888-720-9677. That's 888-720-WNPR, or leave us a comment on Facebook and Twitter at Where We Live. So, Dr. Omer, you're on several committees for the World Health Organization. What are your thoughts about lifting the pandemic emergency status? And can you talk about any gaps in public health messaging?
Well, I think it was a reasonable decision to lift the public health emergency of international concern, which is the official term the World Health Organization uses for these kinds of events, because it's unsustainable to continue that because it has actual costs associated with something like this, but also it can have an impact on attention to other health conditions, etc., especially in countries with limited resources. Having said that, I think part of the messaging should have been that, look, even if this declaration has been lifted, this disease is of significant importance because it is here with us for the long run, at least. And the fact that it still causes many times over deaths compared to, let's say, influenza in its steady state should mean that we continue to pay attention to reduce the impact of this virus.
And with what you just said, how would you describe the stage of the pandemic we're currently in? You know, as you just mentioned, this is something that's going to be staying with us for a while. You know, have we reached the so-called endemic phase that we've heard about really, early on?
So it's not like flipping a switch that, one day you reach that stage. But yes, we're well into that level where this disease will see increases and decreases, in various populations, but it is with us for a while, at least, unless we come up with strategies to aggressively control it further, look, elimination of any virus or any bacterium is never out of question, but for the foreseeable future or for now, I think we should consider this disease to be with us for the long run.
Right. And as we talk about how it will be with us for a while, most masking and prevention-focused policies here in the U.S. have been eliminated, and along with a lot of major testing and tracking efforts as well. And experts also have been saying that transmission rates currently on the rise again are likely drastic, undercounted. So are we back to normal? Is that a thing? What are your concerns there?
We're certainly not back to 2019 or 2020, but we are at a stage which some are classifying as quote unquote new normal. I don't particularly like that term because, it's non-specific, but it does in a way signal that we are at a stage where some of the drastic measures that were useful in very early stages are not implemented. But that doesn't mean that we don't use other tools in our toolbox to control this virus aggressively to reduce its impact, especially amongst the most vulnerable. So again, it's that kind of a situation where things are not back to before this virus emerged in humans, but it is certainly not the first few months or the first year of the pandemic.
And I want to touch on the vulnerable population in a second, but what strategies would you recommend to control COVID-19, aggressively or otherwise, or long-term plans maybe?
Yeah, so there are two things. First of all, I think we should focus on pandemic preparedness and preparing for sort of larger surges, even in this virus and other pathogens, et cetera. So setting that aside specifically for COVID-19, I think, first of all, we should focus on things that require some attention, some investment, but are somewhat passive in the sense that do not require day-to-day compliance from people, because that compliance we know and we documented. Look, even by July, August 2020, we documented there was pandemic fatigue. Even people who started with high level of compliance had lower levels of compliance. So that does not mean that people shouldn't voluntarily wear masks when there is a high risk situation and where their own condition warrants. But I'm talking about at the mass level. So one thing we should do is put in place measures like improving indoor air quality. There is investment. There is federal funding. There are other resources. We know a lot about doing that at a somewhat lower cost. So certain kinds of filters that have been evaluated and are now recommended, and air purification systems, especially in places where some of our most vulnerable live. Not just in homes, absolutely. In homes, I think it's highly recommended, but also in nursing homes, in schools. And this is not just helpful for COVID-19, but other viruses, et cetera, like influenza, like respiratory syncytial virus, and so on and so forth. We should also focus on making sure that the really good vaccines we have reach the populations for whom they are recommended. So currently, the emphasis of global and even the inflection of the U.S. recommendation is focusing on the most vulnerable, like the elderly, like the immunocompromised individuals, like pregnant people, and so on and so forth. And so making sure that vaccination is not available, but our education campaigns, our community engagement efforts ensure that there's a higher rate of uptake of these vaccines. As we do that, I think investments in the next generation of vaccines that actually interrupt transmission of the virus, not just reduce its impact once the transmission has happened. And these vaccines were doing that, by the way. We documented it as well, and others documented it, until the Delta variant. It's the Omicron where that game changed, where they were still and are still reducing the impact of the virus, but not at a high level reducing the transmission of this virus. So focusing on vaccines that do so, including intranasal vaccines, including next generation of vaccines, and other vaccines that target proteins on the virus that are not variable, that don't depend or that don't contribute to the emergence of these variants. And so therefore, the more stable proteins, if the more stable proteins are targeted, you can develop these vaccines that work irrespective of the variant. And there are other ways of developing these variant non-specific vaccines. I'll just give you one example. So efforts that happen in the background in a way that it's not sort of something like, let's say, the mayor of New Haven or Hartford or New York or Dallas is implementing, but public health professionals are focusing on. There is enough budget for those investments at the federal level, for example. One of the things that happened in the debt ceiling debate and that kind of a deal was that investments on new generation of vaccines were preserved, and that was very encouraging. And so that is the work that needs to be done, that needs to go on, that needs to keep the rates at a lower level, as low as possible.
And we'll touch more on vaccine access in a moment, but I think that especially with the pandemic, it spotlighted a lot of concerns, especially for the vulnerable population, as you were just talking about now. Do you have any additional concerns around this population that are being prioritized or left behind, really?
Look, this pandemic, especially in early stages, did expose fissures in our society, not just fissures in our healthcare systems. Where I was living in New Haven, actually in the New Haven area, right outside New Haven, when the pandemic started, and in the first couple of waves, the map of deaths in that area overlapped with where the minorities lived. Where Black and brown people lived. That should not be acceptable. But also, this pandemic demonstrated that we as a society are not helpless bystanders, because there were interventions, there were community efforts, there were efforts by various governments, and not just in blue states, but also in red states, to make sure that that kind of a gap is narrowed. And we did make progress in the later stages of the pandemic, where this gap was narrowed and closed in certain areas. But that also says that we should do that. We should preempt those gaps emerging, because the underlying structural issues of our healthcare system and beyond have not been covered, have not been eliminated. So therefore, this should be making sure that the most vulnerable, based on demographics, and in certain rural areas, by the way, there were not as much gaps between urban and rural, on the negative side in Connecticut, but in several states, there were urban-rural disparities that emerged in various waves. So we should make sure that these kinds of gaps do not emerge again, but it will require some effort. But there are other ways of looking at vulnerability. For example, those who are in nursing homes. We didn't do as good a job as the moment demanded to make sure that those people who live in nursing homes are protected. In terms of pregnant women, that they remain a vulnerable group in terms of this vaccine, and with seasonal and other surges, I think the immunization rates are not at the level where we want them to be among those who get pregnant and women who go through pregnancy and childbirth and so on and so forth. So that kind of focus is what is needed right now.
And we've been talking about accessibility in a lot of different levels, and now I kind of want to jump to information giving. Later, we'll hear from Dr. Hotez about his experience of the early days of the pandemic and how he really was focused on speaking with complexity and to not dumb it down to the public. So, Dr. Omer, I want to ask you, how did you consider that when it came to COVID-19? What was going through your mind when you were thinking about how to present this very complex information to the public?
So, look. I'm currently in New York, and whenever I come to the city, I'm reminded of early parts of the pandemic in January 2020, when the cases of this virus were emerging, and there was one confirmed case in the U.S. And I wrote an op-ed on the way back from New York on Metro North. I started writing it early, but I finalized it on Metro North on my way back from the Colbert Show, and his taping. And I wasn't a guest, I wasn't a featured guest. I was in the audience. And I wrote this op-ed in the New York Times. That was, I think, the first op-ed on this virus. It was called the novel coronavirus at that time. And I warned of three things, and with all of them had implications regarding communications related to this emerging pandemic. At that time, it wasn't even a pandemic, that emerging outbreak. Number one, I said that let the scientists lead because they are closest to the ability to synthesize changing information. And I knew that the information will change. Therefore, they should be closest to decision-making, but also communicating. The second thing was we had evidence from previous large outbreaks and even pandemics. It wasn't my first pandemic in terms of response, et cetera. I had been involved with previous efforts. So we know from those episodes that false reassurances can decrease public anxiety in the short run, but that leads to a breakdown of trust in the long run. And the last thing I said was beware of sources of misinformation and disinformation that we are not used to. It will come from unexpected sources, and they shouldn't be unexpected because we can preempt them. For example, things shared on these preprint servers, so papers that are not peer-reviewed but shared very quickly. And having preprint servers is a good thing overall, but it does come with aspects that we need to pay attention to. So with that, I proposed a few things, and I continue to believe in the fact that you share information quickly, you don't give false reassurances, you respect the general public, and I as much as I love our premier public health institution, the CDC, I think one of the shortcomings of that institution was that it didn't treat the general public with the kind of respect that is needed. It tried to dumb down things to see that they cannot, by assuming that it cannot handle nuance. Yes, you have to be clear, you have to be articulate, you have to simplify the steps that people need to follow, but you can't gloss over important information because it, again, backfires. And I think going forward, we have to follow that lesson.
And we're going to take a quick break here. You're listening to Dr. Saad Omer. He's an internationally recognized epidemiologist who was recently appointed inaugural dean of the School of Public Health at the University of Texas Southwestern earlier this year. He was also previously the inaugural director of the Yale Institute for Global Health. What questions do you have about COVID-19? You can give us a call, 888-720-9677, or find us on Facebook and Twitter at Where We Live. This is Where We Live from Connecticut Public Radio. I'm Catherine Shen. The COVID-19 emergency may have ended, but the pandemic is still very much on. Back with us to discuss is Dr. Saad Omer. He is the inaugural dean of the Peter O'Donnell Jr. School of Public Health at the University of Texas Southwestern Medical Center. And what questions do you have about the pandemic? Feel free to give us a call, 888-720-9677, or find us on Facebook and Twitter at Where We Live. So, Dr. Omer, you were on our airwaves actually after the CDC suddenly shifted the isolation guidance from 10 to 5 days, which was also right before schools came back from winter break. And at that time, you really helped break down the scientific rationale behind that, and in some cases, the lack thereof. Can you talk about this as an example of having to speak with complexity?
Look, that was one of the things I think was a shortcoming in the CDC's response, both in terms of policy and communications. So just to set the context, we around Thanksgiving we saw the emergence of a new variant, the so-called Omicron variant, which had a higher level of transmission than Delta because it had what we call immune escape. On a per case basis, it caused a lower level of deaths, and so your probability of dying if you got infected on an individual level was lower, but it spread more easily. So the net effect was eventually we found out was pretty substantial, and hundreds and thousands of people in the U.S. Died because of this. Additional people died because of that wave. But the fact that those data and these signs were there from the first few weeks of the emergence of this virus. Alongside that, a lot of us were saying that actually at that time in certain recommendations, this was the isolation period of those who got infected was actually longer than even 10 days. And we were saying that we should shorten that period because there was evidence to do so. But we were saying to combine it with testing. At that time, there was a reasonable level of PCR testing infrastructure, but we were actually saying that use rapid tests and deploy them more widely. And since the public health authorities saw some bottlenecks there was thinking that because of this wave of highly spreadable virus, there will be major disruptions in the society in terms of absenteeism, breakdown in the ability for people to show up. And so therefore, some authorities recommended that we shorten the period, which was fine, even up to 5 days. But they didn't say that you test out of that isolation. That was the major issue with that recommendation. And that I continue to say that, and a lot of us, who were pushing back on this, have been borne out of, our views have been borne out by what happened after that. And so therefore, the UK recommendation wasn't applied. They did testing as part of their protocol. And so what happened was, yes, people showed up. A lot of people showed up infected at work. And the net effect was that even though the per case mortality was lower, it spread so quickly that the total number of deaths and disease and disability in certain cases was very substantial. We, in the early parts of this virus emerging, we even heard this mistaken notion that it was, quote unquote, a blessing in disguise because this virus will make everyone immune and very few people will die. That was, one more manifestation of the amateur hour that was going on during the pandemic that we saw. And it wasn't just, people who were non-scientists. There were people who should have known better. By the way, what happened during the pandemic was often people who were otherwise, respected folks in some fields were trying to, perhaps filling in the communications gap, were coming up with these perspectives in fields where they didn't actually have experience. So it was like, there were a lot of star players, but often our star football players were playing in baseball games and our baseball players were out playing croquet. And so because of this mismatch in expertise, there was a lot of misperception of what should be done and how it should be done. But also, this recommendation came from one of our public health agencies, during this emergency. And so I think we should learn a major lesson from that episode.
And also learn from a really good sports analogy there. I think we can all use that a little bit more, Dr. Omer. Appreciate that. And really, with what you've just been saying, clearly there were so many things that you yourself and other public health officials were also grappling with. And Dr. Hotez points out that the medical community is also primed to not politicize science, but also that the anti-vaccine movement is increasingly political. So another thing to grapple with is, how would you describe that pressure, or how has that changed in recent years for you?
Well, look, political doesn't have to be partisan. And so therefore, understanding that there are, and throughout, there have been pushbacks against vaccination from more than one side of the political spectrum, and that is factual. People in Vashon, Washington, so the former hippies in Vashon, Washington, had been opposing vaccines for decades, and that aspect of the crunchy granola crowd pushing back against medical interventions has been there. On the other hand, people push back against vaccines from a liberty perspective, and that's not everyone. On the other aspect of it is that there are champions for vaccines on both sides. I'm not a political scientist to know what is the proportion, and just like I said, football players should stick to football, and baseball players should stick to baseball. This is not my. It is not to say I'm not contradicting anyone who wants to go in and have that kind of a perspective. I respect that everyone has their own ability and understanding and background to comment on specific political aspects of it. But from my expertise, I can't say what proportion is precisely on which side of the political spectrum, but historically, it is factual that there have been pockets of vaccine pushback in multiple sides of the political spectrum. It does seem that because of government officials in, say, Florida, etc., and a candidate for the Democratic nomination, there has been some new dynamics that have been introduced in this kind of a discourse. But we should remember that the support for vaccine has also come from more than one side of our political discourse, and that happened during the pandemic as well. One of the biggest successes was the COVID-19 vaccine program. I think we could have done much better in terms of different aspects of immunization delivery and acceptance and that kind of stuff. But I think it was a success. But it was a success because the vaccine was developed, not because it was a success while the vaccine was developed in one administration and it was mainly deployed in another administration. So look, in this whole cacophony of back and forth around vaccines, we sometimes forget that there were, even in this pandemic, bipartisan successes that saved a lot of lives.
And we got about a minute left, but I do want to ask, with the global perspective, what recommendations can you offer as far as vaccines and boosters? Is this something that we should get annually, or what are your thoughts?
Well, I have the privilege of serving on the World Health Organization committee that does develop those recommendations for the world. And then countries adapt that, and US has a parallel system to adapt or develop recommendations around their own populations. And so for those global recommendations, and of course, I'm speaking on my own behalf, not representing any committee, the focus has increasingly shifted for a couple of years, for the next couple of years, on the immunocompromised, the elderly, pregnant women, and some of the other vulnerable groups, for getting these additional boosters, especially the one that came out just now, etc. And the thinking is that we will need to boost the population and individuals in vulnerable groups for the next couple of years. That's the current global outlook. Because these programs have substantial costs, especially for countries that have limited resources, the global perspective has been that we should look at the scenarios emerging and revisit this, after a little while, perhaps in a few months to a year, to see if it becomes an annual thing globally.
And
different countries have had different outlook, but that's what the overall thinking is. That for now we will need it with the emphasis on the immunocompromised, the elderly, pregnant women, those with comorbidities like diabetes, kidney
thank you so
disease,
much,
and
Dr.
that kind of
Omer.
stuff.
Unfortunately, we have to end, but we will be revisiting this. You've been listening to Dr. Saad Omer at the School of Public Health at UT Southwestern Medical Center. And coming up, we'll revisit our conversation with Dr. Peter J. Hotez. Join the conversation, Facebook and Twitter at Where We Live. This is Where We Live from Connecticut Public Radio. I'm Catherine Shen. Back in April, we spoke with another acclaimed scientist in Texas with Connecticut ties, Dr. Peter J. Hotez. He's the Dean of the National School of Tropical Medicine at Baylor College and Director of Vaccine Development at Texas Children's Hospital. Dr. Hotez sat down with us for the hour to discuss his upbringing here in Connecticut and also his early passion for public libraries, microbes, and maps. You can listen to the full conversation on our website at ctpublic.org/wherewelive. He also discussed his new book, The Deadly Rise of Anti-Science, A Scientist's Warning, which is due out September 19th. Take a listen. Dr. Hotez, thank you so much for joining us today.
Oh, good morning, and thank you for having me this morning.
So, Peter, you've been out front and center on the science of vaccines. This is also well before the COVID-19 pandemic. Can you talk to us about what inspired you to write this book, especially since this is basically your third book since the pandemic?
Well, I've been writing books now for a while, and in addition to being a working scientist and keeping up with the grants and the lab meetings and the research papers, and a lot of them are about this rise in anti-vaccine activism because it's so important. And the way I got involved is kind of interesting. I have 4 adult kids, including Rachel, who, when I was on the faculty at Yale, Rachel was diagnosed with autism and intellectual disabilities, actually at the Yale Child Study Center in New Haven. And shortly afterwards, there were false assertions that vaccines caused autism, and this came out with after a paper was published in The Lancet making that claim in 1998. And so I was out in front always saying, no, this can't possibly be the case, and all of the experimental evidence has clearly shown it's not the case. And then I wrote the book. It was called Vaccines Did Not Cause Rachel's Autism, very straightforward title, which went into the evidence showing there's no link in what autism is, how it begins in early fetal brain development. And that wound up making me public enemy number 1 or 2 with the anti-vaccine groups. And so in addition to devoting my life to vaccine science, I found myself, defending vaccines on the front row of vaccine anti-science, and now I've watched it really blow up during this time of COVID.
Well, and that's also sort of the perfect segue into my next question. As you mentioned, your daughter Rachel and your 2018 book, Vaccines Did Not Cause Rachel's Autism, was a very, very personal look at the impact of influential anti-vaccine community and why misunderstanding around vaccines can be so, detrimental and impactful. How would you say, as you mentioned a little bit just now, the mechanics of this movement have evolved since then, especially with what we've seen with the current pandemic?
Yeah, I mean, the OG assertion was that the vaccines cause autism, and that really accelerated during the 2000s. And unfortunately, the anti-vaccine groups at that time had a lot of bandwidth on the internet, and they were monetizing the internet, selling phony baloney autism cures and nutritional supplements and anti-vaccine books on Amazon. And so I was calling that out. But then about 10 years ago, they went through a sea change. The false claim that vaccines cause autism is still with us, but increasingly it became more of a political movement, especially down where I am here in Texas and in the southern United States are on this banner called health freedom or medical freedom, basically, asserting libertarian rights. You can't tell us what we want to do with our kids. And Texas kind of became then the epicenter of the anti-vaccine movement because it got political support. It got actually PAC money from the Republican Tea Party in Texas, and including one of the major PACs in Texas, Empowered Texans, and they even created their own anti-vaccine PAC, their own anti-vaccine political action committee. We got up to almost 100,000 kids denied various vaccines because of this movement. And that's what came off the rails during COVID-19. That same libertarian anti-vaccine streak then really took hold around COVID-19. And ultimately, 40,000 Texans needlessly lost their lives because they refused to take a COVID vaccine. Nationally, the number is around 200,000 people unnecessarily lost their lives because they refused a COVID vaccine during our horrible Delta and Omicron waves and BA1 Omicron waves in 2021 and 2022. So that's why I'm writing and speaking about it. It's not fun to delve into American politics, but I do it to save lives because 200,000 Americans needlessly died because of this stuff. And that's why we have to take it seriously. Because if you're a scientist really concerned about saving lives, now I think it's almost as important as making vaccines for the world to combat the anti-vaccine activism because so many people are dying because of it.
Well, and then you just mentioned that, because of what you just shared, this is not necessarily a new thing that we're seeing in terms of anti-vaccines or anti-science. You took us back a little bit in history, but can we also check in on those early days of the pandemic? How was some of the shifting guidance that we were receiving sort of an example of science at work that maybe people were misunderstanding, like when the masking guidance came out in the first couple of months?
Well, I think, in the early days, there was, when you're learning about a brand new virus pathogen, there's a learning curve. You have to, I think the early assumptions about COVID-19 were that it were going to be like the first two coronavirus pandemics that we had in the 21st century. And there were assumptions made that it was going to be more or less the same, maybe a bit bigger. And it turned out this particular coronavirus had a lot of different aspects. It caused much more thromboembolic disease, cardiovascular events, stroke than the previous ones. And so, the docs and the physicians and nurses and healthcare providers in New York, had learned the lesson the hard way because they got hit very hard. And if you remember in March and April of 2020, when sirens were going off nonstop, they had to learn about anticoagulating patients. So that there was that learning curve. Then there was confusion about the mode of transmission, whether it was through droplet contact, which is the classic mode of influenza, whether it was the same, and not really understanding that it was an airborne respiratory virus. And then in terms of vaccines and the need for frequent boosters, I think that wasn't necessarily understood or adequately conveyed to the people. But, one of the things that I tried to do when I was going on CNN or MSNBC or even Fox News at that time was, not trying to dumb it down. I went into, if you remember, a fair bit of complexity. And I think that resonated with people because I was able to explain my underlying assumptions so that if things did change, then I could say, yes, I did say that. But if you remember, I also said it's based on X, Y, and Z assumption. And I think that was the mistake of the Health and Human Services agencies from CDC and the HHS agencies early on is they clung to this old school style of communication, which was, we got to talk to the American people like they're in the fourth grade or sixth grade and dumb it down and just give summary statements. And I quickly realized that that's not going to work in this pandemic. People, or at least a part of the country, was desperate for real information to protect themselves and their loved ones. So I went into a fair amount of detail, and I think that was very helpful because, for instance, when the first two doses of vaccines were rolled out, I said, mRNA is a new technology, but if it's like any other vaccine, we're going to need boosts. And, that's the way we do our pediatric vaccines. We give a series of primary immunizations. We wait a few months, sometimes years, and then we boost, and then you get more durable and longer lasting protection. And so, saying that, I think was extremely helpful. But then, superimposed on all that was starting around April into the spring, the West Wing of the Trump White House started putting out frank anti-science disinformation, touting the benefits of hydroxychloroquine, saying the virus was like the flu, and saying the hospital admissions were just catch up in elective surgery. And I remember sitting in the green room of CNN and MSNBC and thinking, this I know what this is because I've been going up against it for decades. This is anti-science disinformation. And I called it out, and I was one of the first to call it out, not because I'm so brilliant, but because I'd had all that experience going up against it. And that was one of the first times that it was really explained that this was intent to deceive the American people. And unfortunately, that banned me from the nighttime Fox News broadcast, although the daytime anchors hung in there with me for a little while longer. But I thought it was necessary. That was very tough to do, because then I became a target of people from the far right, of people supporting President Trump at that time. And that's when I saw something game-changing, which was, it wasn't just the usual anti-vaccine groups monetizing the internet, non-governmental groups. This was anti-science aggression or disinformation supported at the highest levels of the government, supported by far-right members of the U.S. Congress, both the House and Senate, the House Freedom Caucus, and then amplified nightly on Fox News. And then I saw them recruit a whole cadre of pseudo-intellectuals or contrarian intellectuals from far-right think tanks to give it academic coverage. This became an entire disinformation empire that actually got worse after Trump left office, and we can talk about that.
Well, I was going to say, here you are in the daytime. So wanted to ask too, you mentioned we were getting a lot of information coming out of March and April 2020, and also talking about there were so many assumptions made from all sides, but in general, there's a desperate desire for real information. And you've been out there in the public, spreading information that you knew. So how can public health messaging address that skepticism without sort of, contorting or kowtowing to it?
Well, I think it's important, one, to like you say, stick by your guns and be able to speak about health and science information in detail and in accurate ways, and not to be fearful of when people weaponize health communication and when they actively promote disinformation, to call it out as such. And it's a little bit easier for people like myself. I mean, I'm an academic professor, but it's, if you're a health official, or if you're working for a local or state health agency, especially in a red state, then it becomes really tough. And then you're trying to kind of strike that balance, and threading that needle is really problem. My wife says I use too many metaphors. Threading that needle could be really, really problematic. But it's so critically important to do that, because now what you're seeing is these anti-science, anti-vaccine groups are not what they used to be. They're organized, they're well-funded, and they're politically motivated, and they have the highest support of elements of the federal government. And so this is formidable. So now you've got, for instance, the Proud Boys marching at anti-vaccine rallies. And so when I'm attacked, it's often from far-right extremists, and the threats are something like, well, the army of patriots is coming to hunt me down, and that's sort of nonsense. And so it is a formidable foe. And I think the other problem that we face is in our scientific and medical communities, there's this understanding that we at all costs, we're not supposed to politicize the science or medicine. And how do you do that without talking about it? So if we now know from studies reported by Charles Gaba, the health analyst, New York Times, Axios, National Public Radio, have all done the analysis, and overwhelmingly those who lost their lives since the first part of 2021 come from red states, and the redder the county, meaning red being Republican, blue being Democrat, the redder the county, the lower the vaccination rate, the higher the loss of life, so much so that David Leonhardt of the New York Times calls it red COVID. And, it's not that I want to politicize it. They politicized it. My view is, look, everyone's entitled to their conservative views, even extreme conservative views, but somehow we've got to uncouple the anti-science from this because it's killing so many Americans. And the problem is the academic societies, the federal government agencies, even the National Academies of Sciences and National Academy of Medicine don't know what to do about it because, the thinking is at all costs, we don't talk about Democrats and Republicans or liberals or conservatives, but what do you do when the aggression is coming from one side? Or to paraphrase Elie Wiesel, neutrality is really favoring the silence, and neutrality is favoring the aggressor in this point. And that's why I decided to speak out and describe it, again, not because I care about your conservative views or people's liberal views. I just want to save lives, and you can't talk about it without first talking about it, and that's what I've done in the book. And it was a tough book to write because it's so profoundly sad. So many, 200,000 lives lost is a societal force. That's one of the most lethal societal forces we know of in modern times in the United States. And yet we don't frame it at that. And I talk about these heartbreaking stories of people who refused vaccines and are dying of COVID, and in some cases in their last dying breath saying that COVID is a hoax. Or at the 11th hour, they said, okay, finally, I'll take the vaccine, not understanding that's not how it works. Vaccines are preventative. They're not therapeutic. Or in some cases, telling their family, don't do what I did, get vaccinated. And I never want to see that happen again. And that's part of the reason for writing the book also.
You've been listening to Dr. Peter J. Hotez, who's the Dean of the National School of Tropical Medicine at Baylor College of Medicine and the Director of the Center for Vaccine Development at Texas Children's Hospital. His new book, The Deadly Rise of Anti-Science, A Scientist's Warning, is due out in September. I'm Catherine Shen. Today's show is produced by Katie Pellico. Our technical producer is Kat Pastor. Download Where We Live anytime on your favorite podcast app, and thank you so much for listening.